Thank you, RC.
Yeah, I'll be here.
Yeah.
Yeah.
Please continue in the chair, all of you, please. And we will go ahead with another presentation. This is all part of our international lectures. We had one from Vietnam on endoscopic thyroidectomy yesterday because he had time convenience yesterday only. We all saw that wonderful video presentation from Dr. Tan Nagok from Vietnam. Now we finished with the video presentations from Dubai. Dr. Alfie did. Dr. Vinod Menon from UK had presentation on hiatus hernia as well as sleeve gastrectomy. This presentation was from Dr. Geeta from Dubai, and now we are moving with Dr. Yasir Amin Latif from Dubai. Dr. Yasir, you're online?
Hello.
Yeah, Dr. Yasir, we will play your video and then we will listen to you. Let me introduce Dr. Yasir. He is Associate Professor of Surgery, Consultant General and Surgeon at Dubai Hospital, Government Hospital, Dubai. Very good friend of us. And at this invitation, I had the fortune of going and operating in the Government Hospital, Dubai on thyroidectomies and parathyroidectomies in the keyhole method or endoscopic manner. Thank you, Yasir, for the opportunity given to us. And he has been part of various conferences at Kochi when we head to Dubai, or otherwise he comes personally to attend our conference. Dr. Yasir's presentation will be on, and then you can speak. Okay, Yasir?
Hello, Badma. It's nice to talk to you. Congratulations for your conference, as usual. And congratulations for all the team.
Yes.
Being well done, and we enjoyed it, honestly. Sorry, I'm going just very quick about our experience of transoral thyroidectomy. And when I used to visit any place, they give me a talk about the anatomy sites where you feel more safe for doing this procedure. We used to do minimal access thyroidectomy through axilla, breast, but it's a long journey to go to that area. So we start doing oral trans to the vestibular area, which you are, I think, in India, you started as well doing this type of surgeries. But we been encountered for the last times with many injuries to the recurrent laryngeal nerves, and even a bit damage to the neck. It looks post-operative, not that beauty. And just I want to talk about quick tricks and about the point that might be helpful for our colleague for performing the surgery. Transoral is a procedure that you get an access through the vestibule area of the mouth, going to the neck, and then finding the thyroid and tackling it one by one, which we do it as usual in conventional or through the trans axilla. So I want to just highlight a few points. You can go for next slides. You control the slides. So yeah, the main important thing.
Hi, Yasir. I'm here.
Yeah.
Hi.
Amin, hi. How are you?
I'm fine. Fine.
All right. All right. So you control the slides, yeah?
Sure.
Sure. So the main point here, we have got the nerve when we put our trocar, and this mental nerve, we try to avoid injuring of it. So we need to locate it anatomically from where it's coming, So if you go for next slide, I can show more.
Yasir, we cannot hear you, Yasir, now. Doctor.
No, can you hear me right now?
Yeah, now you are audible.
Yes, can you hear me?
Yeah.
This comes from preola in the fourth mandibular tooth, and this where it's coming from. So when we put our incision, we try to go above around 1 centimeter, and the middle one into the cerebellum, which we go a little bit up where the muscles. I'll show the muscles. Can you see this? Show me the next slide, please. Yes, next one. Not controlling here. Yeah, this is the way we'll put our trocar to introduce it through to the neck, where we put 5 in both sides and 10 milli in the middle line. Next slide. This is a nerve distribution where if you injure it, you get huge numbness, and this can disturb the quality of life of the patient. And sometimes if you manipulate it so much, you get neuropraxia, where the patient also suffer for some times. Next. Yes, you see here, you can look to the muscles. When you put our middle incision above, at the split of the mentalis muscles, in this area, you can avoid a bleeding. So if you go a little down, you may have huge bleeding. That's why we use a cauterization in this area. And next slide. I can show you, this is the way where we introduced our first trocar, where the muscle of mentalis, that's been split apart, where we put our trocar, the live trocar 10 millimeter, were introduced into that area, which is very important when we talk about platysma and the shape of platysma, how it comes in this area and how much is inserted. So next slide. I think that I had sent you a presentation where not being well arranged. Anyhow, when we introduce the trocar into this area, we have got the platysma, which is originally actually from the fibers of pectoralis muscles going through all the neck. And it goes the first fold in the hyoid and then into suprahyoid, where it ends in the part of the mandible and a part of the fibers goes up here. So this is an area of challenge where you try to go underneath of it, pulling the muscle up. And in this area, what we know it is submandibular space. Here, the platysma, it is not having that thick layer, like what we find it in down of the neck. So the rest of the muscles of the suprahyoid, they are more prominent in that area, where many people, they be encountered with severe bleeding when you introduce that your trocar. So the idea is when you put your trocar in that area, don't try to manipulate it so hard. Just try to push it into the hyoid bone. Go next slide. And I can show you the anatomy of platysma. Platysma is very important muscles which can keep nice shape of neck. And as we do minimal axis surgery into the neck, we used to say this is a very and gives very nice shape. But honestly, if you start damaging the platysma, usually what could happen, the skin will stuck into underneath the structure. So it gives you a stiff neck, So you have got a trick that you have to leave in decent way, go into avascular area. Next slide. Next slide, please. This can give you a shape of how it looks like. Next slide. Next slide. So Yes, this is a way where we introduce our trocar into suprahyoid area mandibular. You know, this is an area, it gives a lot of bleeding, and I believe people who have been doing transoral thyroidectomy vestibular approach, they can understand what I'm saying exactly. So you don't need to manipulate your trocar at that area. You have to go directly into hyoid areas. Keep a good distance for moving your hand around. And when you introduce it into hyoid, you go above it and you try to create your space, and this is vascular space. You pull it up, a bit of air, and then you are into a very nice place where you can see the cricothyroid cartilage, and underneath into the sternum notch. And then you create your space where you can get sternocleidomastoid on both sides, and now you are into area of vascular. Next slide. So this is a quick understanding about anatomy of thyroid. Next slide. We know, all of us, the blood supply of thyroid is coming from inferior thyroid artery, superior thyroid artery, thyroidemia, and the drains also take the blood back into vein drains through middle thyroid vein, and superior thyroid vein, and inferior thyroid vein. Next slide. It would be very interesting to talk about recurrent laryngeal nerve and relation of it. So the right recurrent laryngeal nerve turns through the subclavians, and the left one through the arch of the aorta, and it's located between, in the groove of tracheoesophagus groove, and prominent in the left side rather than the right side. The right side migrates, go all over, where supply the thyroid from one side. You know. Next slide. So definitely, when you do this, it can show you a bit of conventional, when we do conventional thyroidectomy through the open procedures. You know, then I think I have got a very clear slides coming on. Next slide. Next one. This is very important slides. Please go back. Thank you very much. This is very important, can show you why it looks is not clear. This is very important, can show you that the recurrent laryngeal nerve's relation of the inferior thyroid artery, sometimes it goes, actually the most of the time in the right side, it goes behind it, and around 50%. And also we can find around 20% to 25%, it might go between the branches of the inferior thyroid, right inferior thyroid artery, and in few times around 15%, 10 to 15%, we find it above the inferior thyroid artery. This is in case of the right side. In case of the left side, the lower part, the most of it does not go. It goes between the branches more often than going behind it, and above it is around also 15%. Next slide. Definitely, when we do open thyroid, we try to locate the recurrent laryngeal nerve by identifying the triangle, which we call lost triangle, where the trachea will be medial and the great vessels will be lateral, and superiorly by inferior thyroid artery. This is very important when we do it through the transoral we see this triangle in different way around, you know. So the inferior thyroid artery is one of very important structure that we will talk about it in a bit of details. Next. Next slide. This is not clear slide to go through it. Next one. Next. I think I go next. Next. Yeah, this is talking about the superior recurrent laryngeal nerve, superior laryngeal nerve, sorry, and the relation of it. Go still the slide next. Next. Next slide. I have video here which can show that in clear. It is not in this presentation. Bear. Hello? No, go. Then let me I talk about superior laryngeal nerve. Above. Go. So in superior laryngeal nerves, which is very important structures that we go to Joel's triangle, where go up, please. Next slide. Next slide. Next one, please. Yes. So your triangle. This is not. Excuse me. Just back again. Back slides, please. Back slide. Back slide. We're going into back slide here. No, go back again. Back slides.
Which one?
Yeah, back still.
Yeah.
Go back. More back. More back. Yes, that's it. So this is very important triangle. Also, we encounter in this triangle when we do transoral. I'll talk about the details when we go for the procedure itself. So what we do, definitely we have got strap muscles, which when you pull it, it will be in the upper border, and trachea is stayed in medial side. Lateral side is superior thyroid pedicle, that when you pull it into lateral side, this is the triangle space, and you get cricothyroid muscles in the floor. In this area, you will find the superior laryngeal nerve. Next. In different space. Next, please. You see here, yes, back, please. Yes, you can see it here clearly. This is the strap muscles, and we have the trachea, and we have the pedicle of the thyroid that being pulled into the lateral sides. So the nerve is situated in this area crossings, and sometimes has got different places. If you divide this place into 3 parts, the max of it will be in the upper part, and half of it will be in the middle, and few sometimes will be encountered nearly to the pedicle where attached to the thyroid itself. So it's easy to be injured, and to protect it, of course, being so near thyroid and to avoid the impact of severe laryngeal. In transoral, I'll come and I'll show what we do, and I have video. It will be more clear. Just this give you an idea how to protect these nerves. Next slide. Next slide. Next slide. Also next. Next slide. Next. I want to go quick next. Next. Next slide. So this is for education for medical college. You all know about all this. Just I believe we have to go front to see the surgeries and how we get the trick about it. Next slide, please. Next slide. So they can show you, one of slides can show you the nerve and relation with the muscles,
Dr. Yasir, sorry to interrupt you. Can you make it a little more faster?
Yes, I'm trying to make it very fast because I want to see the track of surgery itself.
Okay.
Next slide, please. Next. Next slide. Next slide. So this is the area where we approach our trocar when we pass from the hyoid area, and where we can see the sternal notch, and this is the deep cervical fascia, and we approach that through the median line, we call it alba cervicalis, as we do in conventional way. We pull the strap muscle aside. Next. Next, please. There's a video here. I can show you. Can you play the video?
We are not able to open a video from the slide which you have sent.
Okay, then next.
Next.
Show you. So this is can show you the approach of that. This is sternal notch, as I have said. This is sternocleidomastoid. This is space. The second space one will be identified. Just we go from the middle as we see, and we put all the muscle one side as we do it in conventional methods. Next slide, please. So when you get the thyroid, you have got two ways. Here you can play the video.
No videos. No videos. Only.
If you cannot play, okay, let me explain quickly. The thyroid in front of you. Some people, they go to take the thyroid into the middle side, forming a tunnel. A great process thyroid itself, where you find the first things, the thyroid, middle thyroid vein, and you be like get it, Or some people, they find that the superior area is more prominent for them and easier to approach it. So they pull the superior pedicle up. So you find the superior pedicle up, and the trachea is down, and you be very near to the thyroid area, and you cut that. This is more safer than you go away from this area. If you go away, the chances of injuring the superior laryngeal nerve is high. And it will be more helpful if you use nerve monitoring at this site. And if you do good dissections, you might be also seeing the superior laryngeal, but it's difficult because it's behind it near to the trachea and cricothyroid. So when you go for the right side and you put it one side and the medial side, so you get the middle thyroid vein, you open it, and you try to be very near to the thyroid. Next slide. Next. So this is the middle thyroid vein, and you try to put the thyroid to one side. When you open it, start to be very near to thyroid. Don't dig down, because if you dig down, you might find the recurrent laryngeal is migrating in this area and easy to injure. So the main important things you have to identify the inferior thyroid artery easily, and be more gentle and be more into the thyroid area. Much of heat can upset your recurrent laryngeal nerve. So when you identify that area, so you have got the carotid, you have got the inferior thyroid artery. Unfortunately, we didn't have the video, could have show you very clearly. Then you can identify easily the right recurrent laryngeal nerve, and you can avoid it easily. Then you can carry out your surgery. Next. Until you end. But main important things, you be staying into thyroid side until you find all the lower structure coming down. Besides, you have inferior parathyroid that's so much being attached, because the right recurrent laryngeal nerve, as all we know, that passing behind the inferior thyroid, inferior parathyroid, and ending up to the superior parathyroid. So they can show you clearly the right, when you pull the upper pole, here there's no video. Badma. Hello?
No video is playing, so you can maybe complete the presentation by showing us the steps.
All right.
Yeah.
Okay. So next slide, please. So this is inferior thyroid, have I mentioned to you. So when you see it, you start like getting near to the thyroid. Don't go away, because the recurrent laryngeal nerve is staying just underneath of it, or above it, or in between. Next slide. Next slide. This is showing the recurrent laryngeal nerve. Next slide. This show you, yes, next slide. This show you clearly the right lower parathyroid, you see? So you have to be very near to the thyroid glands, and you like get all the inferior thyroid artery branches near the surface of the right lobe. Next slide. Next slide. This is the anatomy. This is from cadaveric anatomy. Can show you clearly. This is where you can get a nice tunnel, which is formed by sternocleidomastoid, is the most lateral side, and the thyroid intermedial side. Trachea is behind. This is carotid sheath, and you can also go into central compartment clearance easily. You can approach also the lateral side for lymph node dissections. Next slide. Next slide. Next slide. Sometimes this slide, please. Back. Yes. This is one of the slides can show you recurrent laryngeal nerve. If you identify the inferior thyroid and you don't find the recurrent laryngeal nerve, so definitely yes, you go to the superior parathyroid, and you look to that area, you can get non-recurrent, which is coming directly into thyroid. Or, and this is very dangerous, or may loop beside the artery will be encounter of that, so easy to be injured. Next slide. Next slide. This is the left side. The trick of the left side, the nerve, is going into the groove of tracheoesophageal groove. So when you dissect, always stay near to thyroid. If you start from up or from low,
Dr. Yasir, we
Still
would
way-
request you
the
to
still
conclude
way
because
of the-
you've taken 25 minutes conclusion. Thank you. Please conclude, Dr. Yasir. Yeah, you have the slide reached.
Yes, I have done. I have done.
Yeah,
I have done.
I know.
Unfortunately, the meeting was not there.
Sorry.
And thank you. Thank you very much.
Thank you, Dr. Yasir, for giving us a glimpse of transoral approach for thyroidectomy. Thank you so much. We will just take up the last lecture of this international series. That is from Dr. Mohammad Khayyum. Dr. Khayyum, you are online? Dr. Khayyum's presentation can be on. Sir, your presentation is online. Then we will have a presentation from Galaxy Hospital, Pune. Dr. Shailesh Puntambekar will be giving us an overview of robotic and laparoscopic onco-surgeries. So Dr. Khayyum's presentation will be for another 10 minutes and then we will have the onco presentation.
Good afternoon, MISCON 2020 conference at Kochi, India. I am Dr. Samiha Farhad speaking on behalf of Professor Dr. Mohammad Abdul Qayyum, National and International Faculty, Gynecological and Laparoscopic Surgeon and Minimum Invasive Surgeon. Here we have selected this patient for both gynecologist and general laparoscopic surgeons, as we both face these problems. So, both of us need such knowledge of how to prevent complications in this operation, especially to have dissection of bladder and uterus. This operation was done under general anesthesia with right upper port for ligature forceps and right lower port for surgeon manipulation. Left lower port was used for bipolar manipulation and dissection.
You are watching presentation from Dr. Abdul Qayyum, Gynecological Endoscopic Surgeon, Chief Consultant, Feni Hospital Laparoscopy Institute, Bangladesh.
For safety, here Professor Dr. Muhammad Abdul Qayyum has used his self-created Q colpotomizer system. This can cause upward traction and ultimately good delineation of cervical vaginal junction. This device is very much effective for the surgery purpose, and it is also very much cost effective as well. He never used diluted vasopressin for hemostasis and dissection. Only upward traction was given during operation, and it was clear with no or minimum bleeding. In appendicectomy operation, dissection of mesoappendix was done with Lakeshore forceps, and the assistant used bipolar forceps in holding and dissection of appendix. The surgeon here used intracorporal knot in appendicectomy and suction irrigation with a drain for 12 hours and vault closed by continuous or interrupted intracorporal suture. Professor Dr. Muhammad Abdul Qayyum was affected by COVID-19 and he was admitted to hospital for about 10 days. He was very much eager to do this voice-over by himself, but his current physical condition cannot allow him to do so. So here I am speaking this on behalf of him, and he is very much thankful to everyone. He is especially thankful to Dr. Padma Kumar and Dr. Pai, and for always active cooperation to Ms. Premna. Let's everyone pray for him for his quick recovery, and let's pray for us so that we can get over from this COVID situation very soon. Thank you for watching.
Thank you, Dr. Muhammad Abdul Qayyum. As stated in the video, sir had a difficult time last week, but still he managed to get the video sent to us. When we actually contacted, he was admitted and was just getting discharged. That is the kind of commitment to the profession he is keeping. We are extremely happy that he was part of us. I'm not sure whether he is online, but we will definitely convey our regards and gratitude. So I am extremely thankful to all the chairpersons who are there for this previous session. Thank you everyone. I am not taking each one's name. If any comments are there from chairpersons, we are just winding up the session of international lectures. If anyone wants to make any comment, thank you everybody. We are going ahead to the session which we actually postponed because Dr. Shailesh had little inconvenience due to an emergency oncosurgery. We have the pleasure of inviting Dr. Shailesh Puntambekar. I am sure to the surgeons he is so familiar a name, an internationally acclaimed surgical faculty in oncosurgery, robotic surgery. He was supposed to actually do a live robotic surgery from Pune because of lockdown. We have actually cancelled that and made it into a video presentations. He will be making two presentations. One is on robotic radical hysterectomy and then laparoscopic right hemicolectomy. He is Chief Galaxy Care Laparoscopy Institute Pune, past President of SELSI. I have the pleasure of inviting respected Dr. M. Vijaykumar, Vice Chancellor, Enapaya University, Mangalore. He was formerly Director at Kidwai Institute of Oncology. And we have Dr. Roshan Shetty, Consultant Oncosurgeon from Enapaya Medical College, Mangalore. Can we have the presentation by Dr. Shailesh? Dr. Shailesh, you are online?
Yeah, can you hear me, Dr. Padmakumar?
Yes, sir. Yes, sir.
Yeah, so thank you very much for this opportunity and sorry for the inconvenience.
Welcome to the presentation of Robotic Radical Hysterectomy with the new robo Versius. These are the port positions. The surgery begins by holding the...
Yeah, sir, please talk, sir. Then we'll play the video.
Okay, so we are having two presentations. One of the presentation is on robotic radical hysterectomy. This is a new robo which was installed for the first time for clinical practice at our place, and this is called the CMR Cambridge robotic system. Unfortunately, Pune is completely locked down for the last 5 days and is going to continue. So we are sending you a small presentation of this new robo just to give an idea how we can do this radical hysterectomy and how this robotic system compares with the same kind of robotic system which is existing. I was the first to use the Da Vinci robo for radical hysterectomy way back in 2009, and then after 5 years I left that robotic because of the high cost. This is something which is completely different and it has separate ports. So we can begin with the presentation, and it's a little bit of voice over also with that. After that, we will have a laparoscopic radical hemicolectomy. Please start the presentation.
Welcome to the presentation of Robotic Radical Hysterectomy with the new robo Versius. These are the port positions. The surgery begins by holding the uterus with a tenaculum. We normally start the surgery on the left side. It begins by opening the anterior leaf of the broad ligament and also a little bit of posterior leaf of the broad ligament. The cut in the anterior leaf of the broad ligament is extended up to the round ligament, which gives the mobility to the uterus. The posterior leaf of broad ligament is opened by taking a peritoneal cut medial to the infundibulopelvic ligament. This exposes the ureter, and then we can again come back and cut the round ligament. Once the ureter is seen, you remain medial to the ureter and extend the cut right into the pouch of Douglas. Here, the rectum is separated between the two layers of non-bilious fascia, and this is with the concept of fat belongs to the rectum. So you can see two layers of non-bilious fascia being there. One goes with the posterior wall of the vagina. You come back on the left side and expose the pararectal and the paravesical space. So this is the paravesical space, and that is the uterine artery. Once the uterine artery is cut, then the ureter is retracted laterally and the uterosacral is taken and cut with the monopolar hook. This is done remaining medial to the hypogastric nerve, which is now being exposed. This is the inferior hypogastric nerve. You remain medial to the inferior hypogastric nerve, and then we can cut the McEnroe's ligament using a combination of bipolar and monopolar current. The entire cut is taken right up to the levator ani. The next step is to dissect the bladder. This is dissected with the idea of fat belongs to the bladder. This is the anterior cervicovesical ligament, or commonly called as the ureteric tunnel. One has to be very careful when you want to dissect the anterior leaf or the anterior cervicovesical ligament, and then the ureter is then lateralized by cutting the anterior cervicovesical ligament. This exposes the anterior parametrium with the inferior vesical vein, also called as the inferior cervicovesical ligament or infrauretral parametrium. The infrauretral parametrium is then completely separated using monopolar and bipolar, and the entire parametrium is taken. The bladder can be further separated using the same concept of fat belongs to the bladder. We come back on the right side and take a peritoneal cut medial to the infundibulopelvic ligament. This exposes the ureter, and then the posterior leaf of the broad ligament is cut using the monopolar current. This cut is extended up to the pouch of the Douglas. The anterior leaf of broad ligament is then cut, and along with the round ligament, and the entire infundibulopelvic ligament is then completely exposed and skeletonized. The infundibulopelvic ligament is then bipolarized and cut, and then the peritoneum further distal to the round ligament is cut, and the bladder is dissected further, again with the concept of fat belonging to the bladder. The pararectal space is dissected and the uterine artery is exposed. Remaining parallel to the uterine artery, the paravesical space can be seen to be exposed. The uterine artery is cut. The ureter is then lifted to expose the uterosacral as well as the McEnroe's ligament. This is a type C2 radical hysterectomy. So you now cut the uterosacral and the McEnroe's ligament, taking the cut right up to the levator ani. The next step is to lateralize the ureter by exposing the anterior cervicovesical ligament, which is again exposed, and the veins in the anterior cervicovesical ligament are bipolarized. This lateralizes the ureter further, you can see, and therefore the bladder can be dissected further down. The posterior cervicovesical ligament has an inferior vesical vein, and that is exposed and bipolarized. Again, the infrauretral parametrium is exposed to take the entire anterior parametrium, and the colpotomy is done along with this area. Once the entire specimen is separated, then the nodal dissection is done. We normally do the ileoobturator nodal dissection. This is done with the principle of remaining parallel to the vessels. So the external iliac artery and the vein you can see being exposed, and all the fibrofatty tissue is now being removed. Just remain parallel to the external iliac artery and the vein. This is a new robotic system which is being developed by the Cambridge Medical System. The entire in-situ movements are the same like the other robo existing in the market, and one can see that the ease of doing surgery probably remains the same. The entire ileoobturator nodes are being removed. That is the circumflex iliac vein which forms the corona mortis, and the ileoobturator nodal dissection is complete. This is a picture at the end of the surgery. Thank you.
Thank you, sir. It was a nice presentation of robotic surgery. Should we go ahead with the questions on robotic now, or should we go ahead after the next presentation? Any comments from the chairpersons? Vijay Kumar, sir. Dr. Rosh.
Hello. Yeah, it's
Sir.
Dr. Shailesh. This is Dr. Vijay Kumar from.
Yes, sir. Sir, good evening.
How are you? Hope you remember me.
Of course.
Long time I'm seeing you. Yeah. For the benefit of others, I have invited him when he was there, Bangalore, to operate And at that time, Kidwai never had a robo, so I requested him to work on laparoscopy and did esophagus. I remember.
Yes, sir.
And for your information, that now the Kidwai also has got Da Vinci.
Yeah, I
Where I'm
know.
working now, and Enapai also has got Da Vinci, and also Da Vinci's training center is with us.
Yes,
And I
sir.
had the opportunity to go to Sharjah to see the CMR, what you are talking about.
Yes, sir.
And I just sat for about 10 minutes to see how it works. It was very simple, if you ask me, in the sense it is more like a improvised laparoscopy rather than big instrumentation. So I only hope I will have the opportunity to work like you on CMR also.
Sure, sir.
and
Yes.
and having said that, it was a very good disposition of that. With the way you did radical hysterectomy now, I was thinking that I have seen you doing it in laparoscopy, I have seen you doing it in Da Vinci, and I am seeing now in CMR. I don't see any difference, and for the many benefit of people who are watching him doing radical hysterectomy first time, there is a Pune technique, he calls it, and he has brought it where he operated the radical hysterectomy. His approach is more posterior, and then he goes in. If I am correct, you
Right,
tell
sir. Right, sir.
further on
Right, sir.
that. The ureter is approached posteriorly first, as he demonstrated. Then only you will go to the anterior and the bladder, etc. That
Right, sir.
makes the things better according to him, and that goes by Pune technique. We call it. The credit goes to Shailesh Puntambekar. It's up to you.
Thank you. Thank you, sir, for your nice comments. I mean, it was an honor to come to Kidwai Institute. Thanks to you and your vision. Kidwai started laparoscopic surgery way back in 2012, and it was all thanks to credit to Dr. Vijay Kumar. Otherwise, they were doing open surgery, and now everybody has started doing this. So I'm really
Correct.
grateful to him for inviting me, because finally, when you are the director, you need to start the process. Then the process will take its own turn. So I remain indebted to you, sir. And yes, the CMR robo is a new robo, and it is like a laparoscopy. The intuitive movements are the same. There is no difference except for the fact that you are not putting your head in the console. So your
Correct.
claustrophobia is little bit less, and you can do these surgeries. Now we have crossed more than 150 surgeries. We've done around 50 LARs, low anterior resections, and 50 radicals, and about 25 esophagectomies, and we find this situation quite good with that. So our publication on robotic radical hysterectomy is getting published in Journal of Robotic Surgery now. This will be our almost 18th or 19th publication on radical hysterectomy. And then on the colorectal one is getting published in Diseases of Colorectal Disease. So all this is getting published. So we hope.
Can I ask a question?
Yes,
Can I
sir.
ask a question?
Yeah.
Because you spoke about the cost, I just am curious to know how affordable the CMR would be for the patient. Because you have worked on Da Vinci, now we're working on CMR.
So the CMR cost is not related to the instrument, which is the biggest
Correct.
problem which is there with the Da Vinci. So you have to pay upfront only certain amount of money which you can negotiate, and then every surgery they charge 75,000 rupees, and that 75,000 rupees, either you can take it from the patient or you can charge, but then you don't have to pay the AMC, no annual maintenance contract, and even the instrument cost is not coming to the patient. So all you need to pay is 75,000 rupees per patient to the company, and you have to keep the correct record, and they take an assurance from you of doing about 150 cases per year. So upfront, you're not paying anything. When you do the surgery, only you are paying. So I think that is the key commercial aspect, because
Yeah.
you don't have to buy the instrument which costs $4,000 per, and there are no lives. So if one instrument breaks down during your surgery, you're not worried that it's going to cost more. You can use another instrument because it is not related to how many lives is there. They will give you the instruments till you finish the surgery, and all that they charge is 75,000 rupees. So I think it's a commercially viable, much more viable model than any other case, and the same moments.
Thank you, sir.
Thank you.
We will go ahead with the next presentation, that is laparoscopic right hemicolectomy.
Yes, sir. So this doesn't have a voiceover. If we start the video, I can keep on narrating it.
Yeah, please post the video. Yes, sir.
Yeah. So this is the right hemicolectomy for ascending colon. This is the port position that we use. We use a 0-degree telescope and we use one 10 millimeter and two 5 millimeter ports. Now the first step in laparoscopic right hemicolectomy, however the BMI of the patient is to one should identify the duodenum. So you can see that we are identifying the duodenum because that is the area where the peritoneum is the thinnest. So even in high BMI patients, you will find this plane. And then all you need to do is to go into the retroperitoneal area remaining anterior to the second and the third portion of the duodenum. So you can see, now we have published this in the JMAS, a gauze technique. So you can even insert a gauze over there, but the first step is to start at the level of the duodenum. Once you start at the level of the duodenum, just remain anterior, and now you see the gyrotas fascia. So you can see the gyrotas fascia coming over there. The next step is the only vessel that stands out by holding the colon is the right colic artery, which you can see crossing the third portion of the duodenum. So that is the right colic artery. So you again enter distal to the right colic artery and enter the retroperitoneum from there. So you can see the duodenum, the only vessel that crosses the third portion of the duodenum is the right colic artery. So you go proximal and distal. So we started on the right of the right colic artery, that's where the duodenum is, and then we come to the lower part of the colic artery, enter the retroperitoneum, and then go from the medial to the lateral side. Here the important thing is to identify the gonadal vessels, and one should remain anterior to the gonadal vessels. Now you can see this is the plane which is called as the mesocolic plane. We all talk about mesorectal excision, but this is the mesocolic plane. So you remain anterior to the gonadal vessels, and you can see the ureter always medial to the gonadal vessels. So you can see the gonadal vessels, remain anterior to the gonadal vessels. Then you come to the base of the right colic artery and take away all the nodes. The Japanese people take out the nodes right up to the superior mesenteric vein also, because that's a right colic vein which drains directly into the superior mesenteric vein. But then we are not doing it. It is called as a D3 dissection. We don't do these dissections because invariably we don't get early cancers, and therefore it is not of much value if it is up to the serosal area. So you can see the right colic artery and the vein taken, all the nodes are taken, and once this is taken and completely ligated with the hemoclips, all you have to do, you can see that there is no breach in the posterior peritoneum which is covering the colon. This is called as the mesocolic excision. The lymphatics are supposed to be between this and the mesentery. So initially we thought that the colon is a retroperitoneal structure. It is not. Now you go towards the hepatic flexure, you can see the head of the pancreas there and the second portion of the duodenum. So you keep on going from the medial to the lateral side up to the hepatic flexure. Now you can see the head of the pancreas. Now the only small vessel which crosses the head of the pancreas anteriorly is going to be the right branch of the middle colic artery. So you can see the head of the pancreas over there. You try to go anterior to the head of the pancreas, you will see two vessels going there. One is called as the gastroepiploic vessels which supply, it is called as the colovesical, or this is called as a area where you can see the middle colic artery and the right branch of the middle colic artery and the gastroepiploic which is going, right gastroepiploic which is going towards the stomach. So you clip the right branch of the middle colic artery remaining anterior to the pancreas. Now at this level, if you go below the small mesothelial covering on the head of the pancreas, you will land up into a lot of bleeding. So one should remain anterior to the head of the pancreas and do not enter the head of the pancreas. So we have cut the right branch of the middle colic artery, and again continuing to go from the medial to the lateral side, you can see we have made a window which exposes the liver and the gallbladder. The hepatic flexure is thus taken from the medial to the lateral side. A further dissection of the colon can be continued on the left side, very, very carefully, not to be very aggressive to take the middle colic artery, because if you take the middle colic artery, then it is not correct. It lands up into an extended right hemicolectomy, but you can take just the right branch. Now, once this is done, all the vasculatures are taken, then you can go lateral to the colon and just take the line along the line of cord, which is the avascular line, and you can complete the dissection right up to the ileocecal junction. So you can see the ileocecal junction, and the entire ileocecal junction is now taken at the last. You can see the gonadal vessels and the common iliac vessels going down. So we always prefer to do from the medial to the lateral side. Never do we do from the lateral to the medial side, because it is not of much value. And once this is done, the entire colonic mobilization has been complete. You can see that this is the complete mobilization of the colon which has taken place. And once the mobilization is complete, you can see that we are further trying to go towards the right ureter and the psoas muscle, trying to be very sure that you don't dig. And then ileoscolic side-to-side anastomosis is made extracorporeally. So you just have to do this. You can also do, if at all there was a small nodule in this patient which was there in the peritoneum, and this nodule was also excised at the same time. So this was a small nodule which was remaining there, and this nodule was near the falciform ligament. So this nodule was also excised at the same time. We prefer to do this anastomosis extracorporeally, because intracorporeally you require a lot of staplers, and anyway you have to take a small incision. So the incision size is almost about 5 centimeters. We do the extracorporeally retrieval of the specimen, and then we do the anastomosis. It's a standard anastomosis which we don't want to show, and then we put a drain. The key steps in the right hemicolectomy are to identify the duodenum, and once you identify the duodenum, remain anterior to the duodenum. So our teaching to the residents is right hemicolectomy, you stay right of the right colic artery. For a left hemicolectomy, you open the peritoneum left of the left colic artery, where you see the pancreas over there. So this is the basic idea, and if you do this, identifying the duodenum, 99.9% of the time you will find that this is one of the simplest procedure to be done. So thank you very much again.
Thank you, sir. It was very wonderful presentation, and the anatomy was very clear. Over to the
Yes, sir.
chairpersons.
As usual, it was a good demonstration. And only thing is, there are many people who do from right to left, left to right. People know that. And he demonstrated his technique. And there are people on the right hemicolectomy go from down up. All these technical, their deviations and differentiations are literally is of no use if you ask me, as long as it is done and executed properly. And what needs to be done is a good clearance of the nodal disease, and also the colon with the mesocolon should come out, and that's what he beautifully demonstrated. Congratulations, Dr. Shailesh. It was a good demo.
Thank you very much. I agree that there are various ways. Now, if you see the Taiwanese guys, Jim and Leroy, they do it from the lower side, and in between the legs of the patient. They start at the right ileocolic junction. They put up the entire colon upwards, and they go there. I stand on the left side of the patient with right side a little bit of 35 degrees up. That keeps the small bowel away. But finally, the principles of the surgery remain the same. The vascular critical should be taken first. The nodal clearance should be there. Okay.
So,
Okay.
Shailesh, can you listen to me?
yeah, Dr.
Yes.
Srivastava, please.
I am Ken Srivastav.
Yes, sir. How are you?
It's nice seeing you, and the demonstration, as usual, a crisp one and very informative. I think it was a very long time that I have met you, maybe another year or so.
Yes.
because conferences are out of this COVID era. So Dr. Padma has given us a very good opportunity to at least meet each other. Very nice presentation once again. Thank you very much.
Thank you, Srivastava sir. It was pleasure coming to KL Kapoor Hospital and operating with you at that time.
Yeah, that's wonderful time. I still remember that. Thank you very
Yes,
much.
yes. Thank you.
Chairpersons, any comments? Dr. Roshan? Sir, shall we wind up the session, sir? Dr. Vijaykumar?
Thank you, sir. Thank you very much for inviting us to be a part of this
Thank you,
program.
Kumar. It was a big opportunity. Thank you very much.
Nice of you, sir, to be with us for this innovative program by which actually we could connect more than 400 surgeons from different parts of the world, sir.
Wow.
Yeah,
Very
we
good.
had sessions coming from 9 departments, various hospitals across India, and we had registrations from various universities even across India. So different parts of the world have participated. Faculty, more than 120 faculty, another 280, 300 participants. All together we had more than 400, and all the time there will be like more than 150, 200 participants listening to your talks and video presentation and all the procedures, 14 procedures live done from different centers.
Wow.
Yes, sir. All successfully done in time, and we have another 2 more hours to go, and God's grace was too much in abundance to us, though we had a very difficult time to organize it, but somehow we have completed it, sir. Thank you very much, sir. Thank you.
Thank you. Bye-bye.
Thank you very much.
Thank
God
you,
bless
Vijaykumar,
you.
sir. Thank you,
Yeah, it
Roshan,
was.
and
Thank
Dr.
you.
Srivastava.
Thank you.
We are going ahead with the final set of important lectures.
Thank you.
When I have chairpersons for the session, that is invited lectures, our chairpersons are Dr. Sandeep Kumar, past president, Indian Hernia Society, ex-director, AIMS, Bhopal, chief editor, Indian Journal of Surgery. Then Dr. Krishna Kumar Marad, professor and head of general surgery, Amala Medical College, Thrissur. Dr. Amar Rao, oncosurgeon, Enapaya Medical College, Mangalore. These are the chairpersons for this next session. That will be by none other than Professor Mahesh C. Mishra. He is President cum Vice Chancellor, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, ex-director of AIMS, and a mentor for many of us, and sirs insistent on this conference and educational programs have actually taken us to a major way up, and we are extremely grateful to him, and we would like to listen to Dr. Mahesh C. Mishra on lap adrenalectomy. I'm sure it's a topic which is close to his heart. Over to chairpersons, Dr. Sandeep, Dr. Krishna Kumar Marar, and Dr. Amar.
चालू नहीं है पार्टिसिपेंट्स देखने पड़ेंगे तब देखेंगे सबकी छोटी छोटी
Good evening, sir.
Good evening.
So you will be using a screen share from your end, sir, because videos are not there in the presentation. So you may be using a screen share. We have the option.
Okay, then you can give me the screen share.
Screen share to be given, sir. Yes, sir. Done, sir.
Okay.
यहाँ पे आपको अपनी शक्ल में मिल जाए
I have got the screen share now.
Yes, sir. It's done.
इसको तो खत्म करें, क्या लिखा? Have been used.
Sir, we will try to make the presentation. When it is video, we will try to separately play, sir. Yeah, I'm just going to make the presentation, and we will just change the slides from here once you comment. So, share it.
Okay. Loading the presentations.
Yeah, sir. We are doing it from here, sir.
Okay.
And you can just tell us, we'll change the slides, sir. Oh, no. Sir, please bear with us for a second. We are just going ahead. Sir, please.
Thank you. Thank you, Dr. Padma. Thank you, and welcome, chairpersons, Professor Sandeep Kumar. Greetings from Jaipur. Right now, I am in Jaipur. Can I have the next slide? So I will start with a case scenario. 67-year-old male presented with chest pain, sweating. He was hypertensive on 3 antihypertensive drugs. He also underwent transurethral resection of prostate for benign enlargement in 2006. And these symptoms he had of chest pain, sweating for 6 months, and he was hypertensive for 20 years. Next slide. So his blood biochemistry was within normal limits. His even urinary VMA was within normal limits. NORAD was not elevated, but his serum metanephrine were significantly, they were high. They were also normal, but normetanephrine was significantly high. The ultrasound abdomen suggested adrenal mass of 5 into 4 centimeter. Next. So, and CT scan of the abdomen confirmed the same finding as one would see on the ultrasound pictures, and then he also underwent Dotonac PET scan, which also suggested right suprarenal mass. Next slide, and suggestive of pheochromocytoma. He also underwent MRI abdomen, as nowadays for adrenal masses, MRI has become almost the investigation of choice, which is suggested multilobulated cystic and solid mass in right suprarenal location. Next. He was investigated. Echocardiography suggested severe left ventricular dysfunction. LV, left ventricular ejection fraction was 30% with global hypokinesia. He had degenerative valvular disease, mild aortic stenosis and aortic regurgitation. CT angiogram, no significant stenosis. Holter monitoring was done, which suggested some ventricular paroxysmal picture, and he was receiving 3 antihypertensives and also was added for pre-operative preparation various drugs by the cardiologist. Next slide. He was planned for laparoscopic right adrenalectomy in right lateral position with 4 ports, 2 10 mm, 2 5 mm. And so these were the findings. that he had a minimal blood loss. It was acceptable operative time, and intraoperatively he didn't have much fluctuation in his blood pressure, very small variation, and he had some pulmonary edema. For that, he was kept overnight in the ICU. Otherwise, this procedure went really very well. Can we play this separately, this video?
We are just going to do that, sir. Separately, we'll.
There were two videos. This is the yeah.
Yeah, make it big. Make it big.
So as one would see, we can see the mass was a relatively larger mass. So the key for we can see the right kidney, and the plane between kidney and the mass is being created. So the key to successful ablation of adrenal gland is to not go into the gland, and capsule of the gland, if it is preserved, the bleeding is really minimal, and one can see the IVC medially. And most of the times, if there are no periadrenal adhesions, one gets a good plane between the mass and the surrounding fat, and one should take his or her time when performing such dissection not to invite excessive bleeding, because that is one of the commonest reason for conversion from laparoscopic to open adrenalectomy. Quite often we see a vein going into the retrohepatic IVC, tributary, and that has to be kept in mind while dissecting and making the gland or the mass free. One can deliver it into a bag, which can be a makeshift bag also of whatever is available. And nowadays, large masses we are removing from the suprapubic incision, so that cosmetically it's a acceptable scar. Okay.
We will go back to the presentation, sir.
Yes, please.
Yeah. Okay. Make it big. Yes, sir.
So next slide.
No, presentation only. Next to be.
PPT. Unless you want to go for the other video, and then that will be it. I think then there is no need for.
Yeah, sir. Actually, next slide is a video. Shall we go ahead, sir?
Yeah, the other video.
Oh, yeah, sir.
Is there the other video, Padma?
So we just thought so. We just play for a minute, sir.
Because that video starts. That is little longer, which starts with the pre-operative marking, etc.
Yeah.
So.
Yeah, sir. We will close this and go for the other one, sir.
Yeah.
Separate video. Yeah, sir. We will go with the. Yeah, this is fine, sir.
Yeah, that is the one, just to show that how we plan the port position.
Yeah, okay, sir.
the telescopic port. This is the telescopic port, and we put another trocar in the right to the rectus abdominis. As we are indicating, that is the right rectus abdominis, right to the rectus abdominis, the second port, which will be taking the liver retractor in. Again, this is right-sided adrenal, and these are two other 5 mm ports. One in the anterior axillary line, and another one is the posterior axillary line. So that is the port position. This is the telescopic port, and the three other ports are the for instruments and liver retractor. So that is the epigastric port actually is used for retraction of the liver. And again, as we saw, the dissection plane is created between the superior pole of the kidney and the adrenal mass. If the mass size is decent, that is 3 centimeter, 4 centimeter, then it is easy to locate the mass. It is at times little bit problematic for the normal gland because there is no demarcation, one doesn't see that. So one has to go and really dig that out of the retroperitoneum. And again, one should do very patiently without inviting bleeding, because bleeding is one thing which is difficult to control, and also then it obliterates the vision. And most of the times, if there is significant bleeding, then one lands up with conversion to open. And this is how one can either start medially and go, but generally I start between kidney and the mass, and then go all around, laterally, posteriorly, see the quadratus lumborum, and then come medially and separate it from the IVC. That is the vein I was mentioning, which I am holding now, that drains into the retrohepatic portion of the IVC. And you can see the normal gland also here. That is the normal gland here, which is still there, and that vein has been clipped, and one can use actually the harmonic to divide it. So energy sources which can be used, bipolar energy or harmonic, the ultrasonic energy, or vessel sealing systems. The 10 millimeter vessel sealing system is also quite good, and one can use it like a finger also if it is a smooth tip, to create a plane between the gland and the tissues around without getting into a bleeding issue. So posteriorly it has been separated, inferiorly it has been separated. So now some part medially has been remaining, and that's the normal looking gland here. Some part of it here in this superomedially. Again, this was also a pheochromocytoma, and another vessel comes here. So if one feels to clip it, one can clip this vessel or deal with the harmonic. Nowadays, we deal most of these small vessels, we deal with harmonic, and actually one can do a clipless, sutureless adrenal excision in most patients. But if one is more cautious, then one can put clips, as I have done, towards the IVC, and you can deal with the harmonic towards the gland. The ultrasonic energy has really proved to be a boon for all surgeons in these times. So is more or less the dissection is complete, and this is a little bit more separation from the medially. Again, there are some small vessels which drain directly, which needs to be taken care. So one has to really go slow. Still, the procedure will not take long time, but just take care of the small vessels because they drain directly into IVC, and one can really get significant bleed, and then you end up converting the procedure, which is has to be avoided as far as possible. So more or less now the dissection, little bit more tissue superomedially, and that is where one has to be cautious because that vein which drains into the retrohepatic IVC has to be dealt with so that it doesn't bleed subsequently, because it can bleed post-operative also. Not dealt it properly. Now this patient also had concomitant gallstones, so we will do the cholecystectomy also after dealing with the tumor. So again, you see the quadratus lumborum posteriorly, small attachments with the liver are being taken care with the help of ultrasonic energy. And some small tissue can be dealt with scissors. Now, since this patient also had gallstones, so you can see that this is the CBD here, and we are dissecting around the Caller's triangle almost in the same position. A little bit we flattened the patient. Otherwise, patient was in lateral position, a little bit flattened, and one has to, this is cystic artery has been clipped and divided. And one can see the cystic duct, common duct junction, and then gallbladder cystic duct junction, taking all the precautions not to go close to the bite.
Yes.
And cystic duct and artery have been dealt with. Gallbladder is being dissected from its bed. And then both the gallbladder and gland can be put into the bag and then delivered accordingly. So the gosp is also, one has to very carefully look for any foreign body not remaining inside. So that is it. I think procedure is over.
Yes, sir. You can just, sir, do you want to play the next video also? Next video, or just go to the next slide, sir.
Is there another video?
No, sir, I think the same thing, part of it was played without the front portion, so we will go to the slide, sir.
Yeah, you go to the slides.
Slide. Yes, sir. Sir, you are able to see?
Yeah, this is the gland which we had removed in the previous case. You see the necrosis, central necrosis in the tumor, that elderly person. Next slide. Another, this 17-year-old male, again, high blood pressure, history of a stroke, and detected to have a suprarenal mass 4 into 4 centimeter in right adrenal. NCCT head was done. Next. And he had elevated normetanephrine. So nowadays, actually, normetanephrine is the investigation of choice for diagnosing FUEs, and patient was put on prazosin and beta blockers, amlodipine, and with adequate preparation, laparoscopic adrenalectomy. It was a young boy, and he did well. This was first time I have seen this such a young age, and the patient had developed this problem. Next. This already,
yeah.
we have already.
Yes.
And again, this is another case where this 12-year-old child presented with intracranial bleed actually, and a GCS less than 8. And so neurosurgeons actually operated for this bleed. He recovered. And then naturally such a young child with so much hypertension, and he was diagnosed with left adrenal mass. And this is the case where I have seen for the first time this such a young child presenting with intracranial bleed because of hypertension. Next slide. So this was the child, and we did laparoscopic removal of the adrenal gland, and this child did well. He recovered. His brain status also improved significantly. Next.
हाँ सनी, अब बताओ तुम किस क्लास में पढ़ते हो?
सेवंथ।
और अब क्या खाने का मन है तुम्हारा?
रसगुल्ला।
रसगुल्ला और
चाट।
चाट? अच्छा, चाट अभी थोड़ा रुक के खाना। और अंडा खाते हो?
नहीं।
अंडा खाते हो?
हाँ।
खाओगे?
हाँ।
ठीक है, अंडा भी देंगे। घर जाने का मन है?
हाँ।
ठीक है, घर भेज देंगे तुमको। ठीक है?
हाँ।
That we saw that both adrenal and gallbladder removal in the same patient. Next. And this is very gratifying for small tumors like cons. So this is one of the patients with cons adenoma, very classical orangish, yellowish, small tumor, very gratifying. But one has to be really careful to remove what full gland with this adenoma and fat around it. Next. So if we look at secondary hypertension, the majority of it is essential hypertension. Secondary hypertension is 5% patients, which could be due to renovascular disease, obstructive uropathies, or coarctation of aorta, or metabolic syndrome. But functioning adrenal gland tumors are responsible for quite a significant number of secondary hypertension. Next. And these could be medullary tumors like POs, cortisol secreting adenomas like Cushing's, and aldosterone secreting adenomas like Cons. And of course, we also have non-functional incidentalomas, cysts, myelolipomas, etc. Next. So symptoms, all of us are aware, as already discussed, the sudden and recurrent episodes of paroxysmal hypertension with flushing of the skin, palpitation, sweating, dizziness, tachycardia, headache, strokes, cerebral hemorrhage, blindness, all kinds of symptoms. The classical triad, what is described for PO, is the headache, palpitation, and sweating. Aldosteronism, naturally hypertension and low potassium, fatigue is very dominant in such individuals. Next. Investigations, the whole range of the serum catecholamines, but serum metanephrine, normetanephrine is coming very significant investigation armamentarium for the functioning tumors. Naturally, CT scan, MRI, MRI, all they complement to each other. And so FDG PET scanning now is becoming more and more used for the investigation of adrenal masses. Next. As I mentioned, plasma metanephrine and normetanephrine are the investigation of choice. Next. And then obviously MIBG and PET. Next. Actually, the patient may need more than one drug for control of hypertension. Common ones are the prazosin, amlodipine, atenolol, but as you see, there was a young child who needed almost 6 drugs to control hypertension, and it is really very bothersome. And many a times, one of the patient was taken back from OT table because the blood pressure was not controlled, and finally we managed to do it. Next. So the surgical approaches to adrenal glands, I think there are anterior transabdominal open approach, thoracoabdominal, posterior approach, retroperitoneal. But the endoscopic or laparoscopic approaches began in 1992 with Michel Gainier and one Japanese surgeon doing it for Cushing's disease. And then now people are doing using robotic assisted adrenalectomy also. People have done with cells, nodes, ambulatory adrenalectomy, all have been reported. Next. So factors which are responsible and we determine the operative approach. Naturally, the large glands cannot be dealt with. And what I am saying, when I am saying large, more than 10 centimeter or 12 centimeter size. And of course, the pathology suspect, whether it's malignant or benign, and what we see on CT or MRI, whether patient had undergone any previous abdominal operations, and of course, surgeon's own experience with various surgical approaches. So the patient factors, body habitus, associated comorbidities, they all determine what approach, operative approach one would take. Next. So if it is such a large, a giant is it next? Next slide. Next.